plenary lecture will be presented by Professor Dr. Andrew Hill, the third presentation after ERAS in colorectal surgery and after early detection of leakage. I am glad to present Professor Andrew Hill for his third lecture in this conference. Welcome, Professor. He will present new tactics in antibiotic resistance.
Many thank yous. So let me just make a couple of observations. I've been very impressed by the hospitality of the Egyptian Society of Surgery, and your members have been very friendly to us, and we've really had a good time here. Secondly, I go to about 10 conferences a year, I would say, all around the world, and this is probably one of the most practical conferences I've ever been to. It's very impressive. You've got a wonderful set of speakers who are doing a lot of state-of-the-art talks, and this is the kind of, if I lived in Egypt, I'd want to come to this meeting, and I congratulate the organisers on a very well-run program. Now, I was asked by Hikmah, who's been one of the strong supporters of this meeting, if I would talk about one of their antibiotics, tedizolid, which is tedimap, which is an antibiotic they're promoting at the moment. And I said to them, you know, if you want me to talk about this, then I have to be able to say my own things. And they said that would be fine. So they shared some slides with me that show some objective data I think will be helpful for us. And then I want to make a few comments about the use of the drug. It's not a drug we have in New Zealand, and the reason is because MRSA infection is not such a big problem for us, and you'll see a little bit about that in a moment. But so much of my information about this is from reading, it's not from my own research. So look, we're all very familiar with these common skin type infections or subcutaneous infections, cellulitis, abscesses, and so on. And these are the everyday practice of a general surgeon's life. And while we talk about many obscure things here at meetings like this is the real guts of the matter, the sort of thing we deal with every day. The problem is that these infections are complicated by increasing amounts of antibiotic resistance. So as you can see here, MRSA, this is a study from a few years ago now, but it showed that MRSA infections were very common, up to and well over 50% in many places. But you can see in some of the more developed countries, such as Canada and Europe, you can see that the MRSA frequency is lower. Antibiotic usage is perhaps a little more controlled, perhaps. But as you can see in places around many other places, North Africa, you can see the very high rates of MRSA infection, and this creates a very big problem for us as surgeons. Now, these data are a little out of date now, but they are from Cairo, and you can see here the rates of susceptibility to a variety of different antibiotics, and you can see very significant amounts of antibiotic resistance, and this was back in 2000, so you can imagine what it is now. So you have a real problem here in Egypt, as do many parts of the world, with antibiotic resistance for these relatively simple and common types of infections. So the main driving force behind antibiotic development now is this problem of bacterial resistance to existing agents. Staph aureus, which is one of the most common infections, is very, very disturbing, and new antibiotics are required to deal with this. And these kind of antibiotics need to have a few things. One is they need to be potent, they need to achieve their activity at low concentrations. Pharmacodynamics need to be positive, and at best if they can be given less frequently. So an antibiotic you give once a day is plainly preferable to one you have to give 5 or 6 times a day, and certainly preferable to one you have to give intravenously. Now, in the last few decades, the only new class of antibiotics, as you will have seen outside, there's 3 stalls selling, I can't even say this, oxalidones. We're surgeons, just call them O's for the moment. So these are a new class of synthetic antibiotics. The first one was linezolid back in 2000, and that's been active against gram-positives and a variety of different multi-resistant bacterial strains, and is generally regarded as a potentially quite useful antibiotic. For these particular antibiotics, this grouping has a whole bunch of attributes that are important to us as surgeons. They have a novel mechanism of action. They have a spectrum that is able to deal with multi-drug resistant gram-positive bacteria such as Staph aureus. They have oral bioavailability, very similar to their bioavailability intravenously, which I think is very useful. They aren't easily selected for in vitro resistance, and they don't have cross-resistance with other antimicrobials. So, for instance, many of the penicillin-type antibiotics share resistance with other penicillin-type antibiotics, including the cephalosporins. So these are a completely different class and quite unique. They have a unique mechanism of action, inhibits bacterial ribosomal protein synthesis at a very early stage, and if you're interested in it, they bind to the 23S portion of the 50S ribosomal subunit. I suspect nobody in this room really minds too much about that, especially when you're giving it. But it works very differently to the existing protein synthesis inhibitors that we're all kind of used to from medical school, which inhibit peptide elongation. So this is the reason why there is very little cross-resistance with the antibiotics that we all learned about at medical school and have used in clinical practice and are still using. Now, tadalafil is the latest version. I think it came about in the early 2010s, maybe 2014, and it's a prodrug. So in other words, it needs to be metabolized to make it effective, and it's metabolized by plasma phosphatase from tadalafil phosphate to tadalafil, and it acts in roughly the same way as the other drugs in the class. Has a complex structure that I will be testing you on. You've been sent around a little card that you can, well, I don't think this is actually on the card, but I'll be testing personally over dinner tonight to see if anybody can remember this. Linezolid has had occasional staphylococcal resistance, but tadalafil is not quite the same. In June 2014, the FDA, which is the, as you know, the American drug licensing group, they approved tadalafil as a second-generation drug that had much more potency against MRSA compared to its predecessors. So it's able to kill off a variety of different gram-positives, including Staph aureus, including MRSA, which I think is fantastic. Also good for strep, so the common bugs that cause cellulitis, strep and staph, and also is able to kill enterococcus, which makes it also useful. The other thing that's very useful is that you only need to give it once a day, and I think that's amazing. Many drugs you need to give more often than that, and you only need to give it for 6 days. Linezolid, it's up to 10 days. And you can use it orally, so you can start off IV if you want, but then you can use it orally as soon as you're happy with things going on. It's shown to be active against all of these bugs, some of which I mentioned before, and it has very strong potency against these, which is very important, as you know. As I said, you can use it orally. The bioavailability by mouth is 91%, so that's very good. So you don't have to have you don't have to remember different doses between IV and oral, which I think is an advantage also, because surgeons have got other things on their mind than the exact dosing regimen. And it's not degraded by liver microsomes. There's a few situations which you need to be a bit careful with it. So you don't want to use it in pregnancy, not because anybody knows of anything that's dangerous about it, but it hasn't been looked at closely, and the same with breast milk. Hasn't been looked at in children, in this case under the age of 18, but there's no reason why it should be more dangerous. It seems to be fine in older people, and it doesn't. The nice thing about the way in which it's metabolized, as mentioned before, is that in people with renal and liver impairment, you don't have to adjust the dose. It's also seen as a very safe drug, one of the reasons being that you only have to give it for 6 days, and there are less problems with thrombocytopenia than previous versions of this. And the other thing is that you can use it with antidepressants opposed to other drugs similar to this. So many of our patients nowadays, at least in my country, I suspect in yours, are on various types of antidepressant, and that's an important consideration. So when would you use it? Well, it's a little hard to be absolutely specific about this. Your country is different to mine, and as I said, we don't use this drug very often, and it's usually we're allowed to use drugs like this when we talk to the special infectious diseases people. But the general recommendation is if you're going to use it, the place is for skin and abscesses type things, so bacterial skin structure infections. You can give it once a day, as said before. I think the place really is in places where there are high incidents of MRSA, and that may well be the case here in Egypt. And it's also good for killing strep and staph and enterococcus. So the situation is really of cellulitis it's an ideal situation. Now this is a table that shows a number of different antibiotics that I got down off the internet the other day. The ideal antibiotic for skin infections would be bactericidal, have a prolonged half-life, have MRSA activity, would have oral and IV use, and would kill some gram-negatives. Now, most of these drugs tick some of the boxes, but none of them actually tick all of them. But to be fair to tadalafil, it has got the prolonged half-life, so you can use it once a day. It does kill MRSA, which is a very, very important thing, and compared to the other drugs in that class, it has some obvious benefits. And then you can use it orally, which is not the feature for things like vancomycin, which is the sort of drug we use often for MRSA. So what sort of situations would I be using it in? Well, here's a patient with cellulitis, and if I were living in a high MRSA area, I would be seriously considering using this drug, even potentially as a first-up drug, because it's often hard to get cultures of these people. So you can't prove one way or another it's MRSA, and these things can develop the necrotizing fasciitis quite quickly. So a very bad erysipeloid type leg infection or an obvious staph one, that's the sort of situation you would be considering using these kind of drugs. Now, while linezolid has been approved for use in these other situations, there's no reason in my mind why Tedimerp would actually be any reason why you wouldn't want to use that. So again, this hasn't been approved for this, but there are always situations as surgeons where we have to think about other things. And in a patient perhaps who's on an SSRI and MRSA is a big feature in your local population, then you may need to be considering it for that. But I know that HICMA wouldn't be telling me I could say that, but I just wanted to say that it would make sense given that linezolid's already been approved for these particular ones and the mechanism of action is very similar. So in summary, bacterial resistance to antibiotics is a growing problem. We all know that. We know it's a problem. We're told that we won't have any antibiotics left in the future. Well, we do, which is good news. Tadalafil is the latest and a member of a well-accepted and well-proven member of the class. There are some advantage over the previous class members which are important. So very convenient dosing once a day. You only need to give it for 6 days. Has less side effects potentially, especially with the longer duration of time frames, and you can use it with people on antidepressants. The clinical indications are evolving, not involving, but evolving, and certainly approved for use in skin and skin structure infections, and especially in an environment such as you're in where the MRSA rates are very high. And there may be situations that would be a little bit out of order but would be defendable, I think, where you might consider using it in situations where there was high MRSA situations and you had people with diabetic foot or abscesses. And there has been some discussion of using linezolid in osteomyelitis, so tadalafil may well work there too. So I understand that HICMA have given you a little questionnaire there to see if you've been listening to my talk. Could explain why everybody's been pretending to listen. I quite appreciate that. I'd like to say thank you to HICMA. They've been sponsoring many parts of the meeting, have done a really good job, and as I said, I've been very impressed by the meeting. And thank you for allowing me to present this work. It sounds like an interesting and new antibiotic that we should be considering using. Thank you very much.